right, folks. Well, we are celebrating something kind of amazing today. And this is a first bite first, which I love doing new things. But we are honoring World Hearing Day, which is a very important day. And we're honoring it with a very sweet friend of mine, Dr. Courtney Turner, who's an audiologist from Mississippi. So Courtney is a board-certified pediatric audiologist from Hattiesburg, and she works at the Children's Center for Communication and Development at the University of Southern Mississippi. She's been there since 2015. And y'all, she also suffers from helium hand, where we volunteer for way too much because she's in various leadership roles with ASHA, with the Mississippi Speech Language Hearing Association, the Early Hearing Detection and Intervention Mississippi Advisory Council. And I met her because, Lord, she has volunteered, I think, for a significant period of time with MISHA, with planning convention. And you're there first thing in the morning to the end of the day, making the convention go seamless. And that's how we cross paths. So, hi.
It is. Hi. Yes, I have served with MISHA, so our state speech and hearing association, really since I was in graduate school. I would help and volunteer as a student, and then as soon as I graduated and went out into the professional world, I knew I had to continue that service, and so
Yes.
I've served on the board in various capacities. When I rolled off the board, I was like, "You're not getting rid of me yet." So this past year, I was convention co-chair, and I'm serving in that capacity again this year. And gosh, I'm just so grateful. Yes, I do have helium hand. I volunteer for way too much, but I mean, if I didn't, we would never have crossed paths.
Yes.
I mean, I like to think that we would have in some way, but
Yeah.
I've met so many incredible people along the way.
I think that's an ADHD superpower.
It
Is
is.
connection. I mean, yes, I see the pattern recognition. We can see patterns quickly and predict potential outcomes. That is a superpower strength. But meeting someone and then having that spark, it's just a beautiful thing. And, but yeah. So to that lovely little hotel that it happens every year that has, y'all, if you want to do a convention, they have a lazy river at the Mississippi Convention. So please put that on your bucket list in September, because it's normally the third week in September.
Yes.
Right? Yes.
Yes. And we will be at the same location, same bat time, same bat place.
Yep.
Yes.
It's awesome. Jackson, Mississippi. And I have, because I feel like an honorary, Mississippi SLP now. And I have.
Yes, you are.
Well, thank you. I have the mustard seed Christmas ornament.
Yes.
But I leave it up year round. And y'all, mustard seed is, yes, biblical reference of the faith of a mustard seed, but it's a nonprofit that supports adults with different disabilities. And they make ornaments, decorations, home decor, and it helps support them. And so a gentleman with Down syndrome with red hair, because he put his little picture on it, made my mustard seed in Mississippi. And precious. Yes. Well,
Yes, it's my favorite.
okay. So how in the blue blaze did you become an audiologist? Because I got to be honest, I didn't even hear about that profession until I was in my audiology class and was like, are those the people that clean their ears? So
yeah,
that's what I knew.
well, and that's such a common experience. Usually, when you ask somebody this question, it goes one of two ways. Either they had a family member who had hearing loss. They have had this personal experience with hearing loss, or they were going to school to be a speech pathologist. I was going to school to be a speech pathologist. Okay. That is what I thought I wanted to do in life. My mother is a special education teacher. And so I grew up in that world. I grew up doing a lot of volunteering with individuals with disabilities and was really drawn to speech pathology. as a career. And as you know, as speech pathologists and audiologists, they do undergraduate together.
Yeah.
And so, yeah, that was really the first time that I learned about the field of audiology and what that entailed. And really, for the first 3 years of undergrad, I fully intended to go to graduate school to be a speech pathologist. And I had one course with the late Virginia Berry. Anybody who practices or has gone to school in Mississippi, they know that name. She would joke that, you know, she was the one that would pull people to the dark side to audiology. But she taught the course on educational audiology.
Okay.
And it really sort of bridged aspects of speech pathology, but for children with hearing loss, and how it impacts, how hearing loss impacts children in their speech and language development and in their academics. And that is when I knew, okay, this is it. This is what I want to do. I don't just want to be an audiologist. I want to be a pediatric or an educational audiologist.
Okay, so full disclosure, this is so far from what I do, right? I mean, in all honesty, I have worked with children that have hearing loss in the framework of early intervention when there's literally no one else around and they find their way to me. And
Yes.
then that's when I phone a friend and go back and hit the books with the mantra being, if you want to wear your hearing aids, and we have to wear them and not eat them or throw them away or chew on them because they're not a teether. But also, I'll be honest, I had not heard of educational audiology until Mississippi, until I was at your conference. I didn't even know because it's just not in my wheelhouse.
Right. But it's so surprising that it was Mississippi.
Yes.
Where you heard of this, which is, I mean, incredible. I'm flattered.
I'm embarrassed. I was like,
don't be.
That's a thing? And Kim told me about it. She goes, yes, Michelle, it's a thing. And I was like, oh shit.
Yes. Yes. Kim she is the best. She is one of my mentors as well. When Virginia Berry passed away, that is when she joined the faculty at Southern Miss. And so she was my hooding professor.
Oh, that's a special bond.
Mm-hmm.
Oh,
mm-hmm.
yeah. Oh, that's deep.
Yeah.
Okay. Well, for all of the other SLPs in the room that don't have a clue what educational audiology is, please make us more gooder, as my children would have said.
I would love to. So, and our school-based SLPs are probably going to understand this a little bit more intimately, I guess. But children who have hearing loss, we know that hearing loss impacts their speech and language development.
Yes.
It snowballs to where it can affect their cognitive development even. Which impacts their academic success. An educational audiologist sort of bridges that gap between what happens at their clinical audiology visit, so where they're maybe getting diagnosed with hearing loss or where they are being fit with amplification, and then what happens at their school. Or in my case, even their preschool, their early intervention setting. Yes. So the educational audiology, takes what happens at that clinical audiology visit and helps translate that to a way that helps their educational team really understand, this is the impact of that hearing loss. This is how it's going to affect what speech sounds they can hear or can't hear. And then here are the accommodations that they may need, the assistive technology, the modifications to the classroom that are going to help them be successful in an educational setting. So just really helping other professionals understand the educational impact of that hearing loss. But then also monitoring the impact of that hearing loss in their academic setting. We also can manage sort of school hearing screening programs. A lot of times, educational audiologists who are actually in a school district will oversee that. We are really helping communicate between the school and maybe they're managing clinical audiologists. Like, this is what we're seeing in school. These are maybe some speech errors or some issues we're having with the technology. Can you address this at their next visit?
What do you mean technology? Do you mean like the type of hearing aid?
So, yes. So their personal hearing devices, so their hearing aids, their cochlear implants, maybe they have a Baha.
Okay,
also,
start there. Go from there. Because I never know. You know all of these things, but like I never know what the correct terminology is for the hearing aids. And I know that's so basic, but for those of us that are out, I mean, like I have a little one that just got fitted for a hearing aid. And so, but the problem is English is not the native indigenous spoken language at home. So the family doesn't have access to an interpreter at the audiologist. And
that's so good.
Oh, yes. And they've politely declined an interpreter, which is okay because they have family members that speak pretty good English. I mean, I don't want that to sound patronizing. Like, to me, it's exemplary to learn 2 languages, but
yeah, for sure.
There's moments when I feel like because we don't have somebody to translate the medical piece that we're at, that there's I feel at loss for how to help or how to ask the questions for them to ask the questions of the specialist. Right. But she got hers and she's like, how do I change the battery? And I was like, oh, honey, that is above my pay grade. So that's where we're at, love. So help me.
So, yeah, I mean, and that's the other, advantage of having an educational audiologist on staff. They may not be able to be there every single day to check that hearing aid every single day, but they are there to provide the speech pathologist or the teacher with the tools that they need to be able to do that, and just the coaching and the education to help them feel confident in doing those things. Because if a child has hearing loss and they are using some type of amplification, if it's not working during the school day, we have wasted everybody's time that day.
Yes, or at home when we're learning it. And that's, and you know what I am hearing and what I have heard previously in early intervention is, well, they don't like to wear them, so they take them off and throw them or hide them. Or I had one child actually eat their hearing aid. And mom didn't realize because it was missing until she changed the baby's diaper.
No.
I was like, she's like, do you know how lucky we are that it came out? I was like,
I mean, and hopefully it was just maybe the ear mold part that they ate and not the hearing aid itself.
I didn't ask for photographic evidence when she relayed that. But like, all I could think of was, well, hopefully the battery part came out because if the battery, like that could be life altering. But But there are, what I do know is my little friend has, Tiana, isn't that the princess from, with the little green frog?
Yeah, Princess and the Frog,
Yeah, she has Tiana on her hearing aid. And so and I know what a cochlear implant is, but I don't know how to label the type of hearing aids or use the correct terminology.
Right. And each type of technology is going to be designed for a specific type or degree of hearing loss. Okay. So when I talk about types of hearing loss, there are really 3 main types. Okay. It can be, and I like to think about it as like we're working our way through the ear, like working our way through the auditory system. So if we start on the outside,
Mm-hmm.
And I'm trying to keep in mind that some people will be like seeing this video and some people will not. They'll just be listening. So I'm trying to sort of describe what I'm doing here. But if we start on like the external ear, the part that you can see, anything going on from that point on the outside of the ear up to like where our eardrum is in our middle ear system, anything happening along that pathway that is impeding how we hear, we call that a conductive hearing loss.
This
Now,
one Bear had, my youngest. So
okay.
Bear had conductive
Yes.
hearing loss, chronic ear infections.
Yep.
We had to have bilateral eustachian tubes placed 4 times.
Yep.
I had to put like a little silver circle thing down in his ear one time. It
Yeah.
looked like the chain link in chain link armor. That's what I thought of.
Wow.
But that's what let him hear. And it was
Yeah.
fluid retention from all the chronic ear infections.
Yeah.
Yeah.
I mean, people don't realize that, having a significant conductive hearing loss is sort of, I think of it as the equivalent sometimes of like if you were to plug your ears up.
Yes.
Imagine going through life like that. A lot of times people think, oh, it's a conductive hearing loss. It's not a big deal. If you are an infant or a young child who is learning language,
Yes.
it has a big impact.
Yes.
Even just
Yep.
that little bit of hearing loss, it can have a big impact. So, I mean, these are things like, yes, chronic ear infections, ear canal, atresia, or narrowing even. We see a lot of sort of narrowing of the ear canals, especially in our kiddos with Down syndrome, microtia, or even anotia, where the external portion of the ear is affected. So those would be what we would call conductive hearing losses. Sometimes they're medically treatable. Sometimes they're not. Sometimes they are more permanent types of things.
Okay.
Then as you move deeper into the internal portion of the ear, the inner ear, that is where we're looking at like our cochlea and the way the cochlea functions to pick up sound and turn that into electrical potentials that then travel up the auditory nerve and then up to the brain where the real magic happens. So anything going on in that inner ear portion that is impeding our ability to hear, to get that sound signal up to the brain, we would call that a sensory neural hearing loss. And that typically is not going to be medically treatable. It's not something that is typically going to be reversible. We can't, take antibiotics and clear that up.
Wait, but can't certain antibiotics cause that type of hearing loss?
Yes, they can.
Okay.
There are certain medications that are considered ototoxic. So they can have an impact on that inner ear system.
And there's the condition, oh my gosh.
Auditory neuropathy?
No.
No?
Yes. No, but there's like a illness that cytomegalo.
Yes, cytomegalovirus or CMV.
Okay.
It is one of, or I think it is the most common preventable cause of permanent congenital hearing loss in babies.
So, to my knowledge, aren't certain states having policies so that they can test for it? Because I read, Caterpillar, the book.
Yes.
Yes, I can see her face.
Valerie Abbott.
Valerie Abbott, but she was huge in like the business professional world, like a finance, like boss bank lady. She's like power suits, power meetings. And then her child had hearing loss. And she ended up writing this entire book and has become this huge advocate for CMV, which is how I know about it. And when she was telling me, like, you have to get tested right at birth, or a child could be hearing until they're 4 or 5, and then all of a sudden their speech starts deteriorating. And, sometimes they could even be clumsy because it's changed like vestibular system. You're like, what's going on? And it's that virus. But each individual state, because of state rights, has to adopt a policy to test for this virus immediately, like 24 to 48 hours after birth, which is crazy to me that's not like a automatic thing.
It should be. So, there's a nationally recommended panel of newborn screenings, like conditions that we screen for at birth. And I know like the National CMV Foundation has been trying for years to get CMV added to that list, because I know for Mississippi, what our state has adopted legislatively is that we will screen for everything that is on that recommended list.
Good.
But CMV isn't on it yet. And so there has been some legislation introduced to try to just add CMV to what Mississippi screens for. And it just hasn't been successful. And I think it's one of those things where unless you have a personal experience with it, unless you've seen it, it's hard to conceptualize, how big of a deal this is. And there's just such a lack of awareness. There was a really interesting study that looked at mothers' awareness of different congenital conditions. And it took the awareness level and then put it side by side with how common the disorder, the condition actually was. And there's such a mismatch. Parents are so much more aware and familiar with diseases that are nowhere near as common as CMV.
Dude, I'm telling you what, I was a basket case the entire time I was pregnant with both kids, because all I could think about was every single week it was like, okay, I had this patient that was born at this week. I had this patient that was born at this week. Like this potential, anytime I got a cootie, but because of what we do.
Yeah.
Oh yes.
I spoke with my OBGYN when I was pregnant, my first pregnancy, and I was working in this early intervention setting where I was around high risk, babies all the time. And I was like, can I get tested for the antibodies?
Yes.
I just want to know, have I already been exposed? I just need to know. And she looked at me like I had 3 heads. What are you talking about? That's not something you need to be worried about.
Yes. But actually,
it's something you should be worried about too.
Hey, guys, if you're pregnant and you're listening to this, I'm sorry. But been there, done that, as I pick up my boobies that, once upon a time they were really perky, but I've nursed 2 children and that ship has sailed.
That'll do it.
But okay, so we have conductive and sensory neural, and we were listing off potential etiologies of the sensory neural. And you said one before I was trying to word recall CMV. You said something about neuropathy?
Yes. And that isn't even one of the 3 main types. So I'll get to that one in just a sec. The third type is mixed. So this is where you've got both conductive and sensory neural. So now I'll get into auditory neuropathy, because that is, its own sort of beast. And again, another condition that there's not a lot of awareness about. And this is where, the easiest way I think to explain it is there is, the cochlea is functioning as it should. It is picking up that sound. It is trying to transform it into a form where it can be sent up the auditory nerve to the brain.
Okay.
But there is some sort of disconnect between the cochlea and the auditory nerve.
Okay.
Or with that auditory nerve, sound is not getting up to the brain like it should. it's auditory neuropathy spectrum disorder because the impact can vary. The impact of that condition on how well that sound is able to travel to the brain, it can vary. You may have children who present with auditory neuropathy. When you put them in a sound booth and you test their hearing thresholds, they are responding as if maybe they've got a mild hearing loss. Whereas you may have other children who functionally look like they are profoundly deaf. So a wide range of how this can look, but regardless, we know it really, really has an impact on like the quality of the sound reaching the brain. And it's something that everybody needs to be aware of. It's something I see audiologists who are testing infants who are not as aware of this as they should be, because there are certain types of tests that this won't show up on. There's a common sort of screening that's done sometimes in newborn hearing screenings, sometimes in like early childhood screenings called OAEs. If you screen OAEs on a child who has auditory neuropathy, they're going to pass.
Because you're only testing the conductive, right?
Well, you're only testing up to the level of the cochlea.
Yeah.
You're not testing past the cochlea.
The OAE is the little tube that goes in the ear with the foamy thing, and then they push the button, right?
So, yes, they are usually going to put some kind of probe in the ear. They're going to press a button. It's going to play some pairs of different frequency stimuli. And the way I explain it to families is that it's going to play these sounds. And if the cochlea is receiving those sounds, it is going to send sort of an echo response back. And that is what I'm looking for.
One of the audiologists that tested Bear one time perforated his eardrum doing that. And she pulled it out, and she pulled out blood on it. And then when the audiologist was trying to explain to me that his reaction, which Bear started kicking, screaming, and hollering like a stuck kid because he was
what shoved it.
No, that happened afterwards. He was calm in my lap, and then she perforated his eardrum. And the ENT tried to say I had a child with a behavioral problem. Bear in mind, bless her heart, Leslie, I love you, Leslie Wilfong at the time. She was my graduate student. She's happily remarried. But Leslie was like, I would like it if you brought your son, because I brought her with me because I thought this is a great opportunity for my graduate student to see what like an audiology exam is like in the real world. She was like, can you please come get him tested in the sound booth at the university? And I didn't know U of SC had a sound booth because I didn't go to school there. So I brought him in, and Danielle Varnado, who was the clinic director and one of my mentors on the South Carolina Speech Hearing Association board, when I told her what happened, she said, honey, what the hell is going on over there? Yeah. And that is how he started with really good comprehensive care. But like, it was terrifying. And we changed practices and changed ENTs and the whole 9 yards. But no, not a behavioral problem. Somebody perforated his ear.
Yeah. I mean, families, they'll get frustrated with me because if they need some kind of specialty testing that I can't provide, or if they are transitioning out of my program and are need to find another audiologist, I always say, it's really important that you find a pediatric audiologist.
Yes. It turned out that woman was
pediatric.
Yes.
And there are not a lot of us. And, I hate making recommendations like that where I know that this family is going to have to travel an hour and a half to get to that appointment. But I tell them it's so worth it in the long run. It's going to save you extra visits.
Yes.
It makes a difference.
Yes.
Children are not tiny adults.
Absolutely. And my lived experience as a mom has profoundly shaped if I have a concern as a therapist that a child's not hearing, I make sure that I refer them now to UVA pediatric audiology. I say, please consider going here. They have pediatric audiologist specialty practice, or over at DC, depending, where they have loved ones that they can stay with. Back home, it was, go to U of SC, because it was, we knew that they had stellar pediatric audiologists. Yes. This was a huge, huge squirrel, but okay. So we had
squirrels are great.
Squirrels are great. Sorry, we have the ADHD brain, but we have the Roku art backgrounds, and one of them that pops up is a giant squirrel photo. And Waffles thinks it's it's coming for her. And so, which is why we have it on there. So whenever the giant squirrel pops up, Waffles is like, rah, 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 and it's just kind of cute, but,
that's amazing.
Yes. Okay. So conductive hearing loss, sensory neural. Mixed is when it's in between.
Yes.
And you have to make sure that you're using the correct screening tools, because otherwise you could miss the sensory neural hearing loss.
Yes.
And all of that dictates what type of hearing aids are prescribed.
Exactly.
And so I'm rusty, but I have the one that goes over the ear.
Yes. So that, a traditional hearing aid, a BTE, behind the ear hearing aid.
BTE. I knew there was a cool acronym. Okay.
Yes. And there are, certain manufacturers who make pediatric specific models of hearing aids. And it is so, so important that is what we are fitting on young children.
Folks that are listening to this and not seeing this, the stress on her beautiful face when she said it's got to be a pediatric hearing aid was like,
it just has to. I've been doing this for 10 years, but it feels a lot longer than that. Not in a bad way, but I just the amount of just things that I have seen over the span of 10 years, it's a lot. I'll go into a school and I'm working with this kid, and he's 5, and he is wearing these hearing aids they're not designed for pediatrics. They don't have a tamper-proof battery door. So he has very easy access. He has access, and so do his peers. It's like, so do his classmates. Anybody can get into that and get that battery. They have tactile controls on them, where all you have to do, which if you're and this was 10 years ago, so things have changed with hearing aids in that span of time. But if you're an adult, I can see how, okay, that's pretty cool. If you want to change your hearing aid program for a different environment, or you want to turn the volume up and down, all you have to do is just kind of sweep your finger back. But can you imagine for a kindergartner how much havoc that can wreak? If all you have to do is just sweep your finger, and it completely changes how the hearing aid functions and responds to sound.
Bless them. That makes perfect sense why so many want to tear them out. And I mean,
oh yeah. I always yes, with toddlers especially, you'll see a lot of that, pulling hearing aids out. But I tell families with that sort of thing, it's just, if it weren't the hearing aids that they were ripping out, it would be something else. It would be their shoes. It would be their pants. It's that age where they are trying to establish some sense of control or independence. They are testing you.
Yes.
Ask me how I know.
So, folks, her and I had fun. Adult beverages after hours. Who was there? It was you, me, Melissa, and
Jenna. I think Jenna.
Jenna was on the end. Yes. And the convention had just wrapped, and the 4 of us were sitting there having a cocktail. And then, of course, like moms, it devolves into, mom stories, and everybody's got a mom story. But I'm the only one at the table that doesn't have a girl. So when they went down the girl rabbit hole and sharing their girl stories, I was like, I got nothing. But establishing feral dominance, that's, yeah.
It is. And so, when you encounter that, that is something that you have to treat as purely a behavioral thing. You're going to treat that just like you treat, any other defiance from a toddler. You're not going to give a big reaction. You're going to, as soon as they pull it out, you are going to calmly say, no, we're going to wear this. We're going to put this back in. Now, on the flip side, if that is continuing and like your typical behavioral modification strategies are not working, that's a red flag to me. Like that tells me that those devices are not programmed appropriately for that child.
So we should follow back up.
Yes. We need to see, like, is it malfunctioning? Has the child's hearing changed? Are they no longer going to get any benefit from it? Like what's going on here? Or do we have some additional sensory processing things going on that we need to explore?
Yes. I've seen the little ones that have, it looks like a headband helping to hold them on, but it wasn't, it didn't look like it was for I want to say BTS, but that's my sister-in-law's favorite band.
BTE.
BTE. Okay, all right. I was like, I'm going to get there. But so the BTE, is there anything that helps hold those on?
So the way like the BTE typically works is, so you've got the actual hearing aid that like sits behind the ear, and then you've got a piece of flexible silicone like tubing that attaches to a custom ear mold.
Okay.
Like that ear mold is custom made for the child to fit in their ear. So like that in itself should help keep the devices on. But little ones are active. So there are a lot of other accessories that can be used to help with retention. So like the headbands, there are things, there's ear gear, there's ear huggies. I think the headbands that I see a lot are ear suspenders is what they call them. So there are a lot of options out there just to help keep those in place, but also to help, kind of like a pacifier clip. Like if they fall off the ears, they're not lost in the park somewhere. They're just hanging from the kid's shirt.
That's brilliant, because literally I've had caregivers say, well, if we're shopping, it falls out and we'll never know.
And these are things that, like, if you go to a pediatric audiologist, they're going to know these things. They're going to inform the families. And that's, another reason it makes a difference.
So if we carry on over to the next one up the rung, is that a cochlear implant?
Mm-hmm. So a cochlear implant, this is typically going to be for our kiddos who have those severe to profound hearing losses. Or maybe they have a configuration of hearing loss that is really, really impacting their ability to hear and understand speech, because that's our main goal with any type of amplification for an infant or a young child, is for them to be able to access spoken language.
Yes.
That is our main goal, is just audibility of speech sounds. And for certain types and degrees of hearing loss, a hearing aid just can't provide enough benefit. It can't provide that audibility that you need. It may provide some audibility. And that's where we kind of run into conflict sometimes with families, because they're like, but they can hear with their hearing aids. They are responding. And I'll hear it from other professionals too, and from teachers. They're like, they're fine. They turn to their name. And so we have to do a lot of education on, there are different levels of auditory skills that build upon each other. Detection of sound is that very, very basic level. And yes, with hearing aids, or for some kids, even without hearing aids, like they may have that very basic level of detection for some sounds.
Okay.
And so for some kids, they may have a significant hearing loss that is mainly affecting their ability to hear high frequency sounds. So like a lot of consonant sounds, like yeah. Um, but they may have okay hearing in the lower pitches, the lower frequencies. So vowels, ooh, ah. So, if you've got a kid, and, I'll use my child, for example, whose name is Olivia, you call their name Olivia, they're going to hear parts of that. And or they're going to detect parts of that. They're going to turn, maybe.
But what if their
That
name's
does not mean that they
Francesca?
can hear.
Yes, but what if it's, I always thought, I think Francesca is a beautiful name, right?
Oh, yeah.
But like, that's so many high frequency sounds in that name.
Right. And like when you think about the way that that babies develop spoken language, it's based on how they hear. And if they're not hearing certain speech sounds, they're not going to learn to produce them correctly. But we also know in the English language that there are certain speech sounds, certain combinations of speech sounds that carry a lot of meaning.
Yes.
When we get into, grammar and syntax and things like that. And so that can lead to some significant delays in their phonological abilities. If you can't hear the S sound, how are you ever going to learn plurals?
Yes. This is the immediate application
Yeah,
from speech to academics, which
absolutely.
makes me think of like Dr. Kelly Farquharson's research
Yeah.
and the work that Angie Neal advocates on back in South Carolina, and Kelly's in Florida, but like on speech sound disorders carrying over to literacy. And like
Oh,
that's huge.
absolutely.
But if we have the speech sound disorder because of a hearing loss, now it's like a trifecta of need.
Yeah.
And this is something, and I'm going to say this very gracefully, y'all. So please don't read anything into it. It's just a simple statement, right? We have researchers sometimes teaching some of our classes that have not practiced clinically. And while it's a beautiful thing to give birth to research, to expand our horizons. It's that clinical application piece. Our profession births clinicians. We don't, our research exclusives are very rare, but that's when I start fretting, especially when I look at like, curriculum and syllabi, I'm like, okay, but where are we teaching the application in the real world? Because that's.
Well, and hey, Asha, if you're listening, I love you. I
Yes.
love you. But why are you mandating that faculty in a clinical doctorate program, a program that is producing clinicians, why are you requiring that so many of them have PhDs?
Mm-hmm. Yes, as opposed to a clinical science doctorate or, I guess an educational doctorate is a terminal degree.
Well, and I know that some of that stems from just universities in general,
Yes.
and their requirements for faculty, and I
But
get that. But
also,
we've got to take a look at that, I think, a critical look at that, because we're seeing faculty shortages. And
everywhere.
here I am going off on I just finished some research on this, so I'm like going off.
This is
is a squirrel.
relevant research. This is a great squirrel because we have to do better because our patient census is increasing. Our patient census is increasing because we're saving babies that we weren't saving because technology is improving. So our need for audiology and speech pathology services are ever increasing. I'm thinking ECMO babies are increasing. And
Yep.
okay, so for those of you that aren't familiar
And
with
ECMO
ECMO,
is a risk factor
huge.
for congenital hearing loss.
Yes. Okay. So ECMO, folks, if you're not familiar with it, if a patient suffers from HIE, hypoxic ischemic encephalopathy, or they have a series of strokes, either in utero during the birth process or immediately after the birth process, ECMO is this terrifyingly cool tool that rhymed and I didn't mean for it, where they take a giant needle and put it in the carotid artery, typically on the right side. And they take all of the blood and drain it out of the baby's body. It goes literally around the room and then goes, is it back in the femoral artery on the left side, I think. I could have that backwards, but it actually cools the body's temperature so that you're essentially inducing like hypothermia, and it's supposed to stop all of the additional bleeding in the brain, but it causes sensory neural hearing loss. And I have had children that, because of Columbia being right there, they had the ECMO center, and I've had kids that have had ECMO with sensory neural hearing loss because of this, as well as dysphagia, which makes sense because of paralysis of the vocal fold and on the side where they actually put the first giant needle in. It's like, it looks like a Vienna sausage going in these little infant snacks. But
and I love that you are aware of that.
Yes.
Like that is one big thing I would say to SLPs who work with the pediatric population, like regardless of whether you're school-based, medical, clinical, whatever. If you are working with the pediatric population, you need to be aware of those risk factors for childhood hearing loss. And the Joint Committee on Infant Hearing has a table. I mean, they have a very comprehensive position statement published, but within that, there is a table of risk factors for hearing loss. And with a lot of these risk factors, the recommendation is actually that even if they pass their newborn hearing screening, if they have any of these risk factors, they need to be referred for diagnostic testing.
Yes.
And that is a piece that does not happen often enough.
And okay.
And you can be the person who catches that.
Yes. And to piggyback on that, I didn't realize how frequently the hearing screen, what is it? What is this? The box called that connects?
The algo?
You have to get the equipment tested to ensure that
calibration.
Calibration. This is the word.
Yeah.
Yes. So folks, you have to have there's whole companies that come in annually and calibrate the tools that do the screening. So my question becomes, how often are pediatricians getting their equipment calibrated? How often are schools getting their equipment calibrated? And then piggyback on, it's the same as my statement to doctors and nurses. How often are they getting their stethoscopes changed? Right? If we're checking for a heart murmur, like how frequently do those specialists get their hearing screened? Right? So it's the same to me of listening and ruling out for a heart murmur is the same concept to me of checking out for hearing. Are we checking the tools that are being used in this screening process to ensure that they are still valid and reliable? Because they may pass in the pediatrician's office because of faulty equipment. And then when you advocate, we go over.
Yeah. Or, there may be a lack of training there. I remember when my children were having their hearing screened just at the pediatrician's office for like a well visit. And they'll have equipment where they'll press the button and it'll play the sound. And they would press the button and look at my kid to see if they responded.
Yes. Or
they see you.
Yes. Well, this is fresh in my mind because the boys just had their annual visits 2 weeks ago. No, it was the first Friday in January. And bless his heart, Goose Danger grew 5.5 inches last year. What? No wonder he had migraines. He had adolescent migraines, 5.5 inches. I thought I was losing my mind. I bought so many freaking shoes last year, but we now know why. But the kids have had their hearing screened because I had grad students practice on them their entire lives, right? And Goose came back and he goes, Mom, she did it all wrong. She kept pushing the button too quickly. There was not enough pause time. And I was like, shh, because the walls are so thin. They can't.
That's amazing.
But like my 13-year-old knew that the screening implementation was wrong. And I was like,
yes.
I was like,
this is why, like, you have to have a strong, like, early hearing detection and intervention program in your state.
Yeah.
To provide the awareness, the education, the training to these medical providers, to these birthing hospitals. It just doesn't always happen.
No, it doesn't. Okay, so we're going to wave a wand to get back to where we started at the beginning. We have had a tiny human maybe fail their newborn hearing screen, or for whatever reason, or they fail a screen. They go to the pediatric audiologist because we're sending them to the correct person. Yes. And they get fitted for a BTE, for a, let's go with moderate conductive hearing loss of the high frequency range. And my case study is now in 4-year-old Head Start, and we're getting ready to go into kindergarten. And the school district actually has an educational audiologist on staff, which I'm so curious about because I feel like that's not a thing. But like maybe they live in a major city.
It just depends on your state and your city on where you are.
What? Okay, so we'll put them in a big city like Chicago, because St. Patrick's Day is coming up and they dye their river green. And I always thought that was really cool. So now I think I've only flown through Chicago as like once. So totally just pulling this out of the katukas here. But what does a day look like for the educational audiologist?
So I am in a very different setting, a very unique setting. So my day might look a little bit different, but I'm going to try my best to.
That's okay.
To sort of what I would expect that day to look like for them. They may serve multiple school districts in an area, or at least multiple schools. So there's a bit of travel involved. I would say really, really busy times are going to be when kids are coming up for eligibility evaluations or reevaluations for special education services. Because for those kids who have hearing loss, they are going to need to do more educationally relevant testing with those children than what, maybe your run-of-the-mill clinical audiologist is going to do.
What does that look like?
So really common things that I'll do, something called a functional listening evaluation, which is really important because if you're looking at a kid, you're trying to evaluate if they are going to need special education services, which I'll tell you, like, there are school districts who will evaluate a child who has hearing loss and not rule them eligible for services. Yeah.
How?
Because most of the time, the criteria that you have to meet to be ruled eligible for special education services through an IEP, the criteria for eligibility under hearing impairment is A, you have to have that diagnosis of hearing loss, but B, you have to show adverse educational impact of that hearing loss. So if you are in on an educational team that does not include any kind of specialist on hearing impairment, if you don't have an educational audiologist, if you are in a district, and this is pretty common, where it's going to be the SLP doing most of that testing for eligibility, an SLP and a psychometrist, they are primarily going to be looking at just some very basic, cognitive, developmental things, speech and language. And with kids who had really solid early intervention, a lot of times they'll say, well, they are they're not scoring low enough on these evaluations. They're not showing enough of a developmental delay to qualify for special education services. So where an educational audiologist would come in is we would do something called a functional listening evaluation or something similar to show the adverse educational impact of that hearing loss. Because we know once a child with hearing loss gets into a more like a classroom setting, you're going to see the impact that background noise is going to have on their ability to understand speech. You're going to see the impact of distance and reverberation, like classroom acoustics. Those are all things that are going to have an impact on that child's ability to hear, to understand, to follow what's going on in the classroom, to participate in what's going on in their classroom. And you're not going to see that when you're doing an assessment with a child in a small, quiet room, one-on-one.
Well, that in the classrooms change. Think about the gym or the art room. Or, I mean, God help you, what about when you go to music class? I mean, the boys' school back in South Carolina, they went to bi-weekly, they would have Mandarin drum lessons.
Oh, wow.
It's so cool. But also, I'm thinking trying to hear and learn in that environment when you're literally learning drums. Like,
yeah. So things like that. And then, I mean, a lot of times your clinical audiologist is going to typically, they're going to do hearing tests without your hearing aids or your amplification. They'll do some hearing tests with the devices, but a lot of times it's still in that quiet, sound-treated room that, is not representative of what that child's educational environment is going to look like. And so I always recommend, especially somewhere like Mississippi, that most school districts are not going to have access to educational audiology. I tell clinical audiologists, please try to incorporate some of these things into your test batteries, especially if you've got a kid who is about to turn 3 or they're already school age, just to help inform that evaluation team.
yes.
Like they need to see, how, not just how is the child hearing or like being able to detect sound with their hearing aids, but how well are they understanding it? Like do some speech perception testing in quiet and with some background noise, because you can simulate background noise in a sound booth to do this testing.
So, in a perfect world, they'll qualify for services, normally with advocacy. In an imperfect world, can you still be eligible for a 504 plan and then have some accommodations? Because I feel like it's the accommodations that are key.
They are. And of course, it's going to depend on the kid. But yes, even if they don't necessarily need specialized instruction through an IEP, which sometimes that is the case, especially if they've had that solid early intervention. Or if they, yes, or if they, maybe they're, an older student and, they're not showing speech and language delays or academic delays anywhere else, and they do just need those accommodations or that assistive technology for access, then a 504 might be more appropriate for them. But especially if you're in a district who doesn't have an educational audiologist or somebody to advocate on that child's behalf, it's going to be up to the parents to advocate for that. And a lot of parents they're not going to be aware of what a 504 is or what an IEP is and how to go about getting one. So that's another way that our clinical audiologists can really help, is just making families aware of these resources and how to go about requesting them.
Okay. So I remember and I'm pulling from the recesses of my brain. I started out as a speech therapy assistant back before that was officially a job title. So I was called the speech teacher. And we had at a different school, because I had actually another speech teacher, but she was grandfathered in because she was, as she reminded me, Miss Jackie was old enough to be my mother. She worked with a little one who had an IEP, but required amplification from the teachers, even though they had their BTEs. I'm learning correct acronyms here.
Yeah.
And the teachers all wore what looked like I don't know, like a remote control on their neck. And it was like hanging. And then I guess it somehow and this is saying something that they had this kind of tech like 20 years ago, 15 years ago.
Yeah.
But what was I actually seeing, and how did that work? There's a fly in here.
Uh-oh. Yeah. So, I mean, if we're talking like 20 years ago, we were probably talking about an FM system.
Yes, that was the word.
So FM, just like, on your car radio, you have AM and FM. And I'm going to try not to get too nerdy on you. But yeah, I mean, FM technology has been available for forever, not forever, but for a very long time. And it is just
days.
It is just a form of like wireless audio signal transmission. So getting that audio signal from point A, from like your microphone, to point B, a receiver somewhere out there.
It was a square on his desk. He had a box on his desk.
Yeah. So yeah, I mean, that was FM technology, and that was fantastic technology to help these children who had hearing loss. Because even if you have a hearing aid or some other kind of hearing device, you are essentially like, you're still listening or hearing through a microphone. And like, if you imagine, you're at an assembly or a concert or whatever, and you've got somebody up on the stage with a microphone stand, if they're standing right there at the microphone, like, you're going to be able to hear them clearly. But the farther away they move from where that microphone is, the less and less clearly you're going to be able to hear them.
Yes.
I mean, that sounds like, well, yeah, no duh. But we have to think about our kids who wear hearing devices in sort of the same way. Like, they are wearing their hearing devices at the ear level. There's a tiny microphone on there. So the closer the teacher is to that child, to their little microphones, the better they're going to be able to hear that teacher. However, that's not your typical classroom. That teacher is going to be all over the classroom.
Yes.
Maybe, 6 to 10 feet away from that student with hearing loss. And so by the time that teacher's voice makes it to the child's hearing aid, it's already, that signal has been diminished by the distance from the teacher or the speaker, from the background noise going on in the classroom. And keep in mind, like, if somebody with typical, like an adult with normal hearing, like if we were to go in a classroom, like, yes, to us, we might perceive it as being pretty noisy, but like, we could carry on a conversation, we could function, because we have adult auditory systems. We have mature adult auditory systems that, from years and years and years of listening experience, our brains have learned how to tune those things out and to be able to focus on who we're talking to.
Yes, and emotional intelligence and self-regulation.
And vocabulary and language. So even if we miss part of what somebody says, we can use our cognitive skills, we can use those context clues to fill in the blanks.
Yes, and tiny
child with hearing loss cannot do that. They don't have those skills.
No. And peers may not have the patience to, I think about like early group projects. They start these group projects in like kindergarten and first grade nowadays.
Yeah.
And the patience to say something again, to say something differently, to to know how to sit with a peer so that they are looking at them so they can pick up like lip movement and facial cues and
Yeah. And again, that is something that an educational audiologist can help with is working with those students on like communication repair strategies and social strategies and self advocacy to be able to express to someone like, hey, can you slow down or can you look at me when you talk to me? Just basic self advocacy things that I mean, nobody else on that educational team is going to think about to address. But yes, so back to FM systems. So today, most of what we would call an FM system, they don't actually use FM technology anymore. Most of the manufacturers of these systems have a proprietary wireless signal transmission system that is very similar to Bluetooth.
oh, cool.
But it's not Bluetooth, and that's an important piece because I will see a lot of school systems and even audiologists who are not necessarily pediatric audiologists. They will recommend like a Bluetooth mic, like in lieu of like a more robust system. And it's not the same. Like the integrity is just not the same. It's more susceptible to interference. Your operating range is going to be smaller. So that's key. It's not Bluetooth. Bluetooth is not really designed for classroom use. When we're talking about hearing assistive technology.
Yeah.
So these are proprietary wireless transmission systems that have been developed by there's two main manufacturers, and these are the two manufacturers who also make the pediatric specific hearing devices. So they have these wireless systems that are specifically designed for classroom use. So they're very robust. They just ensure that that child with hearing loss has the best, most clear access to the speech signal going on in the classroom.
To instruction.
Yeah. Well, to instruction, to peer interaction.
Yes.
All of those things.
What other accommodations does educational audiologists tend to make? Because I feel like placement, like seating, is important.
It is. So I always recommend not just, preferential seating or sit near, a lot of times I'll see like sit near the front of the classroom on an IEP. And that's not always going to be the best place for that student. Especially if you have a teacher who moves around the class a lot, or if you have a classroom set up with like little, like small groups around the classroom. So I always put like strategic, flexible seating near the sound source.
Oh, I like that wording.
So and we have to be really specific about these things, especially in a school district that doesn't have an educational audiologist to like interpret these recommendations. So I try to be as specific as possible in my recommendations, but that one, gaining the student's attention before you give them like verbal instructions. Like making sure like, hey, you've got their attention.
That they're present with you so that,
yes.
Because I know somebody, and I don't have a hearing loss, but if somebody starts talking to me and I'm in the middle of something and my brain is over here, I need a moment to regroup. And, I'll tell the boys, I'm like, mommy was with you, but mommy was processing X, Y, and Z. Please restate what you're saying.
I have to explain that to my kids get so mad at me. They're like, oh my gosh, mom, were you not listening that entire time? I'm like, did you get my attention? Like, did you say, hey mom, I've got to tell you something?
Yes. Yeah. I'm like, no, I was listening, but I wasn't like hearing what you said.
I need accommodations. I need accommodations at home. But like
for neurodivergence.
Yes. And teaching our kids about it too, and to be accepting and embrace it, and just being empathetic of what other people are experiencing, and how they're experiencing life. That's just another soapbox, another squirrel. But
again, that too is welcome here. There's a reason we pray before a podcast, because this Jesus loves everybody.
Yeah. And you never know who needs to hear it. So preferential, flexible seating. A big one. There's so much computer-based instruction and testing now.
Yes.
And you would not believe how many times I've gone into a school, and like, I'm even talking about not even like a public school, like a special school that is specifically designed for students with communication disorders. I'll go into that school and they're all on their computers or their laptops, and the kid who has hearing aids or cochlear implants is sitting there at the computer wearing headphones. I would, from the look on your face, I know that you know why that's not appropriate. But it's shocking to me how that doesn't necessarily cross everybody's mind. I'm
thinking the amount of reverb alone that they're going to get, and no.
So I always put, because, and a lot of times the way testing accommodations work is that you typically cannot add something to a testing accommodation that was not already on their IEP as like an accommodation in their other settings. So I always add in there that any computer-based instruction or assessment, we need to be either streaming the audio from the computer or the device to the child's personal technology using that FM system or remote mic system, because you can do that. Or, and this is mainly for testing, they need to be tested individually, and they need either a human reader or they need to have the audio coming through like the loudspeaker.
Yes. What if they have, like, I know my stepdad, totally different, but he has it connected, like phone calls are connected directly to his hearing aid, and he somehow has
that's Bluetooth.
Yeah, okay, because he has his device connected directly to his hearing aids as well.
Yes. And that typically is going to function through Bluetooth. And so like there are pediatric hearing aids that are Bluetooth enabled. And so you could
theoretically
pair that to the Bluetooth in your computer or your tablet if it has that capability, and stream that wirelessly. But again, that's not typically designed for like educational use.
Yes.
There are definitely certain like caveats to that. And so typically either like having a human reader or having it come through the loudspeaker or having it stream through that child's remote mic.
Yes.
Or FM system.
What you said, it can't just be on test day. This has to be Monday through Friday, what they're used to. Also, I have seen where if it's not done regularly how it's supposed to be done, then it throws off ultimately their testing.
Oh, yeah, absolutely. Absolutely.
Oh, my goodness.
And like just basic things like making sure that we're checking the technology every day when they come to school.
That the batteries are on, that the batteries work.
Right. Yeah. Is it powering on? Even if it's powering on, is the tubing clogged with earwax?
Oh, bless their hearts.
Is there an electrical short, in the circuit? Like hearing aids are tiny computers, essentially. Like they're electronic devices. Here in South Mississippi, humidity and moisture is a major issue with hearing devices. So, like little things like that that could easily be missed if we're not checking these devices every day.
Okay. So, one, we went way over, but I so enjoyed this conversation.
I know.
Much.
I know. I was thinking about that on my way here. Like, gosh, we have so much that we could talk about. Like, how are we going to rein this in?
No. And then we went 14 different ways, but I was like, we need to do like a primer to kind of prep people.
Yeah.
So next thought, could you please come back and do a part 2 on like myth busting for SLPs?
Oh, yes. That would be incredible.
In honor of World Hearing Day, is there something that you would like SLPs that are listening to walk away with? Like, what do you want them to walk away with today? Just
If you have a child on your caseload who has hearing loss, you need to be working with an audiologist.
yes.
If you have access to one through your school district, great. If not, you need to know who that child's managing audiologist is. Who are they seeing? Get a release of information signed so that you can communicate with that audiologist regularly.
If somebody listening has a follow-up question, or maybe they live close enough that like they want to connect with you for like a patient consult, how do they reach you?
So I can give you my email address. It's c.turner, Turner, at usm.edu. I'm one of those crazy people who check my email constantly. So that's usually the best way to reach me. But I'm on social media. If you look me up, I'm on LinkedIn. I check all the things regularly. I'm way too available.
Wait, what is your Instagram handle?
I think it's CG_Turner.
Okay. Yes. Okay.
That tells you how much I pay attention to that. But I am on there regularly.
I mean, I pop on and off, but I'm like, it's so funny to me. I do the podcast part-time. Like I have a full-time job and a full-time caseload, and then squeeze in episodes like batch record, baby. And then
it's impressive.
It's a little bonkers, but a whole lot of love.
Yeah.
So,
Yeah.
yes. Okay. Now, my favorite question to ask everybody. If anybody has any love money left over, is there an organization or a scholarship that they could donate to support?
So the Educational Audiology Association is an incredible membership-based organization that provides scholarships to students as well as practicing educational audiologists to assist with research projects or clinic-based projects. And they just provide so many incredible resources for anybody who is either currently working as an educational audiologist or considering working in that field. So they would be a great organization to donate to. I'm also going to put a little plug for my workplace, the Children's Center for Communication and Development at the University of Southern Mississippi. We are a nonprofit. We're a university-based program, but a good portion of our funding comes from private donations. We do a lot of fundraising just on our own.
Yeah.
So that would be appreciated.
Yes. Courtney, thank you so much.
Thank you.
Y'all, when you meet compassionate colleagues, it's just who really do have a fire in their heart for what they do. It is just refreshing and fills you with hope for the future. So
It
thank you
does.
for being you.
Oh, thank you for being you. You have to grab a hold of these people and keep them close.
Oh, well, Courtney, thank you, thank you, thank you. Folks, be sure to follow First Bite Podcast on Instagram, on LinkedIn. Apparently, we're also on YouTube. So there's that fun, fabulous thing through Speech Therapy PD on YouTube. And as always, we love it when you leave the 5-star reviews. And thank you so very much. So, Courtney, thank you.
Thank you.